Hi everybody, my name is Taylor Green. I'm one of the audiologists here at Audiology Associates.
My name is Rhys Barber. I'm the other audiologist here at Audiology Associates. Now we got a bit of a split one this one. First one's mine, second one's Taylor. Make sure you stay tuned for the second one. I gotta be honest, Taylor's is a little bit better than mine. All right, it's a good one to watch. So this one here, dry skin. Now they're both skin issues in the two videos today. So this one, first one here, you can see is this ring of skin around the outside edge of the ear canal. This is the lateral portion of the ear canal, that outermost portion of the ear canal. This part of the ear canal is actually surrounded with cartilage, so there's a little bit more flexibility here, there's a bit more give to the skin. It's not quite as sensitive as the deeper part, but you can really see this thick layer of skin and wax.
So I was like really focused on that. Excuse my facial expressions. I was like,
you can see it really kind of pulling away.
Yeah.
And when you look beyond it, you can see there's no sort of wax mixed in with that skin further back. So it's just got to this outer section and really dried out. It's become quite keratinous. A lot of that keratin drying that skin out, hardening it up, and it's formed this ring around the outside edge.
So this patient, I can imagine, wasn't having any issues with the hearing side of things.
Yeah, good point. It's not so much because there was a nice big hole right in the middle. What was happening, this patient was having more difficulty first thing in the morning. When they woke up, and we talked about this cartilaginous portion, the outer portion, the lateral portion of the ear canal there. When a person lays on their ear, that particular portion, like we said, has some give. So what it'll do is flatten a little bit. Well, that skin was quite sticky with the bits of wax stuck to it. So those two pieces were sticking together. And because the skin was mobile and able to come away from the canal walls, they were sticking together quite effectively and really blocking our patient up first thing in the morning.
Yeah, they can be quite tricky to remove these. Cause they just get stuck everywhere.
Oh, they do.
It's just
my favourite ones are where they've dried that a little bit more, and then you just get a grip, and it comes out like a donut.
The
whole thing comes away really easily. They're really lovely ones to do. I've switched down here to the fine end, and I've introduced some olive oil. Now, both of those things are going to help with this drier epithelial layer that's come away here, this surface layer of skin. You can see there with the olive oil, it's just softened everything just a little bit. If you imagine having some tough old leather and putting a bit of oil on there just to give it a bit more flexibility, that's the kind of thing we're doing here. And I'm using that technique where we drop over the top of the skin and pull backwards with the suction tube with this fine end. That's going to help it to detach without the risk of sort of lifting it and making it run almost all the way down, which may cause a little bit of sort of surface bleeding there in the ear canal.
And it's more comfortable.
It's a lot more comfortable for the patient. Yeah, much more comfortable. So you can see a massive difference.
Yeah.
Looking lovely and healthy there. Other ear canal.
Same.
Exactly the same thing. Now, what you can get, now on the last video we talked about the medial and lateral portion of the ear canal, the osseous portion, the bony portion, and the cartilaginous portion, lateral portion. Where those two meet, because obviously they've got to meet somewhere because one's attached to the other, it's called your isthmus. And that's a little sort of almost like a little transition point in the ear canal where that epithelial cell layer, using that pond ripple effect, is moving out. It's transferring from one to the other. So sometimes at that point, you will get a little bit of a lift off that surface layer of skin when I caught a rule there.
I was going to say, oh, that's quite a big piece actually.
It's a long old strip. You can really see it going back into the ear canal there. So at first glance, it didn't look that bad, but when you actually start pulling it out, there's a fair old amount in here.
You can't see those bits that are like up in the attic portion of the ear canal. You can't see them behind the...
And sometimes it's like folded paper, isn't it? When you pull the front, it all sort of stretches out and concertinas out, so it's quite deceptive about how much is in there.
Olive oil's gone in again.
Yeah, back to the fine end.
Yeah,
back to the fine end for this one. Now what you'll see me do here is rather than lifting or dragging, I'm actually making a circular motion, so sweeping around the edge of the ear canal there. And sometimes when you've got a grip on the skin at the top and you sweep it around, it does tend to take it all away.
You can kind of see that's starting to kind of peel down the ear canal as well.
That lift that's going down there, you can see, look how far back that's going from this sort of lateral portion heading down towards that medial portion of the ear canal there. There we go. Guys, if you are enjoying these videos, don't forget to click the subscribe, the follow, the like, the heart, whatever you're watching this on, that'd be absolutely fantastic.
Oh, it's really, really dry, isn't it?
It is.
Really dry.
It is. And you can see how paper thin that is. You can see that surface epithelial layer is so, so thin.
Oh, that's what we were looking for there. And usually these kind of just suction straight into the tube and you get a good grip.
But they're hard to spot because when you look at that, well, it's on the viewer's side, on the right-hand side now, that piece has folded back and you can barely see it now.
And that oil helps quite a lot
so.
with that.
Yeah, massively so.
Brilliant.
There we go. So we've got 2.5 centimetres, just, well, that's bang on an inch.
That's an inch, yeah.
Yeah, bang on an inch, that one. So stay tuned.
That was a nice one.
It was a good one.
Oh, we got mine now.
Taylor's is better though. Stay tuned for Taylor's one.
To be completely honest, I can't remember what it is.
Can I remember this one? I had a sneaky look earlier. I got to be honest when we came in.
Oh, I think I remember this one. I think I remember this one.
That is a big chunk, isn't it?
Yeah, big old, what looks like a chunk of wax to start with. So I believe we're going to go straight in with the standard size on the tube here. This patient has already been using oil before coming into us. You can see that kind of sparkly little sort of sheen of wetness around the wax. So we're going to take away this front section here.
It's like a big boulder, isn't it?
It's almost like a little pellet of wax.
Need a little mini Indiana Jones running in front of that one on the way down, didn't you?
So you can see, where this wax was sitting. So this is it was actually stopping this skin from migrating out of the ear canal. So what we've got here is just interwoven. It's very similar to the last video, actually. Interwoven skin, which is all just, again, it's stuck to the ear canal.
That's deceptive because that looks really. It looks soft. It looks
wet. Looked quite soft to start with.
I thought that was going to just go into the tube. I really did.
So you can see we're actually struggling to get a grip on this with the suction. So I was just going to say we do swap tools at some point. So we've got the trusty Rosen inserter. Now, the reason I'm using the Rosen inserter here is because this is a little more on the dry side. I'm hoping that this is going to all hold together. So as we get a good grip through that little gap.
It's certainly pulling forwards, isn't it?
Yeah, you can just see that that's where it's kind of unfolding there. So we've got a little tiny gap that we've spotted at the top.
That's good.
So all I'm doing here is just trying to loosen this off the ear canal. Just trying little sections of this skin. Again, we can't really dig this in anywhere because that's just going to be too unsafe.
And it's because you're in that sort of more medial portion of the ear canal. It's really thin skin.
Yeah, we're in the osseous portion.
Yeah,
Potion.
We can give it a portion. So, it's really thin. Is the skin there? We say 0.1, 0.2 mil thick. It's not very thick at all. So even your Rosen insert at the end is quite narrow. So you could scrape that skin quite easily.
Yeah. So we've popped in here with the crocodile forceps. So where we've got these little bits of skin that are kind of sticking out, we've got somewhere to grip. Now you can already see we've got a good grip on this section of skin here. Very slowly pulling out, and you can just see that. You can just see that as we were pulling that portion of skin, it's actually pulled a little section behind it. So we've got another part that we can grip onto here. Very slow again. We can't just whip this straight out. We don't know at this point if this skin is still firmly attached to the ear canal underneath. We don't want to risk any damage. We don't want to risk any damage in the ear because that will obviously put the patient at risk of infection and they'll probably end up coming back to us saying my ear's hurting. So very, very, very careful.
With that one, because we can't, when we show you can just about see the pars blaster, but you can't see the pars tensa. Now we were talking about the epithelial cells that they're migrating off the eardrum. So if you've got a piece that's stuck quite close to the bottom here, potentially that could be stuck to the pars tensa, couldn't it? So if you go in and you yank really quickly, that sudden momentum of that coming away, if it's attached to the pars tensa, it's going to be really uncomfortable, and B, you could risk causing damage to the actual eardrum itself, which is why you've got to go really slowly for these.
You can see I'm going very slow here.
You are, yeah.
It's very...
It's good the way to do that. Guys, if you're interested, it looks like we're making massive movements inside the ear canal here. We posted a video on Thursday last week which shows that, an outside-in shot, which we're going to try and do one of those every week if we can. But it gives you a good appreciation for how much movement Taylor's making on the outside, which is very, very little movement compared to what you're seeing on the screen there. If you haven't checked it out, it's worth a look. It is worth a look. Well, that's more difficult now, so those looser side pieces have got detached, haven't they?
Yeah, we've obviously broken away these little bits, so there's not much room for us to grip on. We have managed to grip a section here. Oh, it's just tore away. This is what we always hate when we're using the forceps, is we always try to get a really good grip, and we want, obviously we want everything to come out in one go.
Yeah.
But we always do risk tearing these little tiny bits off, and then it ends up leaving, as you can see, leaving these bits further back. So I'm trying to clasp the skin together from the center here.
It's not always easy when the skin's gone almost flat and you've got the jaw of the forceps and you're trying to grab it, it's not going to work. But if you've got a side section, it's easier. So sometimes I will reposition as well when we there we go.
So
there you go.
Funny you should say that, actually.
There we go.
So we're going in with the standard size on the tube again here, just to, as Rhys mentioned, to reposition the skin, or if this has been detached with the forceps, then we can just remove it with the suction. But we've swapped back to the forceps.
Yeah, it was almost, you could see almost that little bit of give, couldn't you? It was starting to move, and then there was that little jolt where it came to a stop, and that shows us it's still attached somewhere. Oh, that's a good grip. That's a nice, you can see it peel on the screen, on your screen, bottom right, but it's coming away nicely there.
Oh, still broke away.
Just tore away. A couple of people in the comments have asked, does this hurt? Like if we're doing eardrum peels, ear canal wall peels like this. I mean, what's your experience? From my experience, patients have never really mentioned it.
No. The one-time patients may...
That's good.
Oh, here we go.
That's a good one.
Sorry, I was looking away then.
That's gone. Wow, that was a good piece. Look at that go.
So you can just see all that skin kind of mixing in and folding in on each other. So we've got the fine end here now just to clean up these last little bits. Going back onto if the patient feels this. The only time really I have personally found patients do feel it is again if that skin is very, very dry and still attached. If we've got these like quite large plugs and we start pulling this out, some people do feel slightly like a little tweak.
Yeah, like a very mild pinch or scratch.
Just where we tear the skin away from the newer, fresher skin underneath. So there we are, guys. That was
quite good. I enjoyed that one. That was a good one.
Doesn't look as much as what was in there.
Do you know, actually, people say this all the time in the comments. How come it looks like huge on the screen, and then when you pull it out, it's like teeny tiny? Obviously, it's magnified on the screen, guys, just so we can see what's going on safely.
So we've got 3 centimeters.
Oh, you left me with inches. It's on the side, inch and a quarter. Yeah. Sorry, guys, the rulers are up right now, so we've got to kind of do this to work out what it is. Inch and a quarter. Well, guys, I hope you enjoyed that video as much as me and Taylor did voicing it over. As always, take care of yourselves.
Take care of your ears.
So we got this, we nailed it last time. Well, it's me that's fluffed it this time.
Put your teeth in.
Take care of yourselves.
And take care of one another.
And your ears. A whole lot. Just take care of everything, guys.
Just take care of everyone.
And
really.
me and Taylor will see you again real soon. I think, I don't know if we're together again this week. Probably not, I'd imagine. But we'll see you both together next week. You'll see me again in a week.
We're always working in different clinics.
Yeah,
so
it's always difficult.
We never see each other.
But we'll see you again soon. Bye, everyone.
Bye.